Welcome everyone to today's webinar. I am Mackenzie Bean, Assistant Editor with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will send you a copy of the presentation to the email you used to register. At this time, it is my pleasure to introduce today's presenters. Dr. James Slover is an Associate Professor of Orthopedic Surgery at NYU Langone Medical Center. He is an adult reconstruction orthopedic surgeon with a practice focused on primary and revision hip and knee arthroplasty. He also serves as the clinical site chief of Langone Orthopedic Hospital. In these roles, the focus is on quality improvement, patient outcomes, and cost effectiveness of clinical programs, research, and education. Dr. Ritesh Shah is a board-certified orthopedic surgeon who specializes in hip arthroscopy and hip and knee reconstructive surgery. Dr. Shah serves as the chairman of Centers of Excellence and on the executive committee at Illinois Bone and Joint Institute. Dr. Shah is a board member of Advocate Physicians Partners and the Consolidated Finance Committee at Advocate Aurora Health Systems. Dr. Shah initiated a systemic outpatient total joint program at Illinois Bone and Joint and Advocate. Currently, Dr. Shah continues his busy clinical practice, research projects, educational lectures, and teaches surgeons on surgical techniques for outpatient total joints, value-based care, and hip arthroscopy. I'd also like to point out Dr. Shah and Dr. Slover will be speaking on finance and orthopedics during October 19th Lunch and Learn workshop at the Becker's Hospital Review 7th Annual CEO and CFO Roundtable. Dr. Richard Iorio is the Chief of Adult Reconstruction and Total Joint Arthroplasty Service and the Vice Chairman of Clinical Effectiveness at Brigham and Women's Hospital. He was the William and Susan Jaffe Professor of Orthopedic Surgery at New York University Langone Medical Center Hospital for Joint Diseases and Chief of Adult Reconstruction at NYU Langone HJD until he left in June of 2018. He co-founded Labrador Healthcare Consulting Services, Responsive Risk Solutions, and the Value-Based Healthcare Consortium in 2015. Dr. Iorio is a national expert in hip and knee replacement and the treatment of osteonecrosis, physician and hospital quality and safety, and a leader in the implementation of alternate payment paradigms in orthopedic surgery. I'll now turn the floor over to Dr. Iorio to begin today's presentation.
Thank you, Mackenzie. So today's symposium is going to be a discussion of the impact of technology and alignment on improving value. And we're going to use total joint replacement as a model for the care delivery system. Total joint replacement is a very reproducible, standardized healthcare enterprise, which lends itself to serving as a model for shaping product lines within healthcare institutions. And the value-based healthcare landscape is changing rapidly. Implementing bundles, both commercially and with CMS, requires an investment in time, alignment, and resources of all the providers who care for these patients. And this includes physicians, nurses, social workers, as well as the hospital administrators. Alignment of these stakeholders is absolutely critical to success. And the discipline necessary to be successful with the bundles is also going to help with all the rest of the product line throughout the hospital and can be extended to other product lines beside orthopedic surgery. As we move toward 90-day DRGs for all payers for total joint replacement, this discipline is imperative to drive success going forward. What about the ACA? Well, this came with a great deal of fanfare in 2010. 45 million people were uninsured, which was roughly 16% of the population. After 2017, after a full year of efforts to eliminate the ACA, there are 26 million uninsured, or 9.1% of the population. Essentially no change from 2016 to 17. So there clearly are more people insured now than there were prior to Obama's election. This CDC survey shows that Americans will cling strongly to their health insurance, and the two groups mostly affected are the healthy working middle class and the poor in states which did not take on the Medicaid expansion. They're the ones that aren't benefiting from these improvements. As we move more toward population health at risk models, ACOs, and bundles of bundles treating arthritis and other healthcare diagnoses, we need to realize that the more patients that are in the insurance paradigm are the ones that are going to be impacted the most and allow us to be successful. But be sure we don't have all of this figured out yet. Payment of specialists within large ACOs and diagnostic groups is not exactly a science yet, and we have a lot of work to do to make this a fair, equitable distribution for physicians as well as hospitals, and the alignment in this area needs to be worked on quite a bit more. As of 2019, MIPS will now be part of the picture. MIPS is the Merit-Based Incentive Payment System. In short, it's a way to bonus surgeons to deliver quality in the Medicare populations. This is a very complicated bonusing system, and one that can be avoided if physicians are in alternative payment models, such as bundle payments for joint replacement. Obviously, this isn't available to everyone, but with more voluntary options available like BPCIA, this possibility has been provided to more than just a few of the healthcare institutions if they should wish. What about CMS? They continue to support the concept of bundling, although CMS has cut back. CJR, they didn't eliminate the program. They realized they made a mistake with CJR and didn't allow physicians to take on risk as episode initiators and required some hospitals to take on risk they couldn't afford. This led to less physician buy-in and a lack of urgency. In those bundles where the physicians led the bundles, there was a lot more financial upside than there was downside. And when hospital-led bundles, it wasn't always as positive. In 2018, CMS opened up BPCI again. This is the so-called BPCI Advanced. This will represent an opportunity for physician groups and physician champions to seize control of the episodes and to optimize management. Unfortunately, BPCIA has target prices that are very low, starting to approach the hospital cost of joint replacement of the DRGs, and that's going to create its own set of problems. But advanced APMs where physicians can take on risk will serve as a substitute for MIPS and will be a more reproducible measure of joint replacement quality than the generalized variables offered through MIPS. There were early flaws in the bundle payment implementation. At NYU, we hired a lot of care managers, mostly FTEs, and hoped for the best. This was fine for post-operative care management, but it doesn't solve the optimization of the selection of patients ahead of time. Hospital-administered bundles without surgeon responsibility have been clinically and financially less successful than the physician-run models. And transparent data. Running these systems without transparent data between hospitals and physicians leads to mistrust and doesn't allow for alignment to be optimized and for the ability of performance metrics to be shared. The hospitals are reluctant to share, but if they don't share, the physicians don't have the buy-in. We're going to turn this over to Jim, where he's going to discuss some of the early flaws and the conclusions from our BPCI implementation.
Okay, thank you. So for the first year of our BPCI, we were able to successfully, relatively quickly, decrease our length of stay, decrease our use of discharge to post-acute inpatient facilities, which led to a decrease in costs. But we had a much smaller effect on readmission rates, which took us a little longer to make progress with. And one of the things we realized in looking at readmissions and how we could prevent them is that we really needed to emphasize the ability to minimize complications. And that to do that, we needed to optimize the patients. So we began to look at various areas where we felt that patients maybe had comorbidities that were modifiable, where we could institute programs to make them healthier so that they would do better with surgery, and we'll talk about that. And we also realized that we needed to develop our evidence-based protocols for blood management, pain, and care management protocols so that even our patients who were low risk were getting the best evidence-based care that they could. So that leads us to the 5 clinical pillars that we sort of developed in terms of bundled payment success. I'm going to talk about the first one now, optimizing patient selection and comorbidities. So we recognized that complications were the key to, or minimizing complications were the key to having success with readmissions and overall patient outcomes. And so we developed a tool to assess risk called the Readmission Risk Assessment Tool, which helped guide us in terms of what areas we could predict we could help in order to minimize readmissions. And it identifies patients who are at high risk so that they can be directed to the programs that affect them so that their risk can be minimized. And what we found is that, again, you can do this by hand, but that's much more time consuming. Over time, in order to be efficient with this, you need to leverage your EMR or other technology platforms rather than relying on the clinicians to do these scores and identify these patients completely on their own. And then once you identify the risk factors in the patients at high risk, you have to have programs to direct them to. And so these were some of the risk factors that we identified led to increased risk for the patients, increased readmissions, increased complications. And I won't go through all of them, but what we really wanted to focus on were ones that were modifiable, ones that we could perform an intervention for the patient to change the risk factor, to make them healthy in order to reduce their complications and readmissions. And initially this program was called POSH, which was perioperative surgical home, and it was initially a surgeon-directed program, and we're sort of moving towards other ways to administer the program to make sure that we get the highest yield from all of these. But we developed interventions in all these areas in order to optimize the patients to reduce their risk of complications and readmissions. And you can see here, this data shows the early success that we had with this. We implemented it, and again, it was a surgeon-directed program at this time in 2013, but we were able to have a positive impact on our readmissions. We still would like them to get lower, but we've had a positive impact with the program. And so I think the key is to identify the patients, have the programs available so that the patients can be directed to the programs that apply to their risk factors. This next slide just is another way of showing, how we were able to improve value. If you start on the right, if you look at the patients that were optimized, meaning they went through the various programs that they had risk factors for and compared them to a control group that was non-optimized, we were able to decrease their length of stay as well as their 30-day and 90-day readmission rates. And the readmission rates are really the key, more than the length of stay itself. But we did have a positive impact once we were able to implement these programs. And this is early evidence that optimizing these patients does allow them to perform better in the short term. And not only did we improve their outcomes, we were also able to, it's directly related, but we were able to improve the cost of the episode as well. So you can see the patients that were optimized, the total cost for 90 days, as well as their post-discharge cost is significantly lower than patients who are not optimized. And that savings comes primarily from reduction in readmissions. There's a little bit of a decrease in length of stay for the optimized patients, but it's really the readmissions, I think, that drives the cost much more, and it saves money on the total episode overall, which is obviously very important.
So then I'll speak about the optimization of the care coordination and patient expectations. So, when we look at the clinical management of the pathway, when you think about the episode of care, the care coordination piece is one of the most important pieces to help a patient get through this their episode of care well, but also from a value and cost-effective standpoint, making sure that it's an appropriate episode of care. So the importance of care coordination includes enforcement of best practices and standardization of pathways. Most importantly, it improves communication between providers and the patient, and the transitions from the hospital stay to discharge home or discharge to a skilled nursing facility. That transition ensures follow-up so that none of the criteria for the pathway are changed, and it optimizes patient education, expectations, outcomes. The idea here is to develop a pathway where at least 80% of the elements are used, and that criteria for exclusion are not determined by the surgeon or the doctor, but really determined by the pathway that's been created. It's really important when we look at management of this that technology does play a role, and care management platforms can improve, patient outcomes. We know that by having an appropriate episode of care, the cost of that care is reduced, and then importantly, it facilitates the physician and patient communication through the care team. The next piece here is the use of multimodal pain protocols and opioid or narcotic minimization. So one of the bigger components of having patients be able to get through an episode of care well in a rapid mobilization or a cost effectiveness or in a safe way, but also in some other things we'll talk about later on today regarding same-day discharge, multimodal pain control is really important. And we want to make sure we focus on preemptive analgesia, specifically non-narcotic preemptive analgesia, so use of Tylenol or anti-inflammatories. Regional anesthesia has been very important for rapid recovery. It decreases a lot of the side effects that anesthesia can cause, such as confusion, or also surgical side effects such as bleeding or venous thromboembolisms. Tranexamic acid has been very important, and its off-label indication is important to note here. It's very important as far as being part of the multimodal pain pathway. And then periarticular injections such as short and long-acting agents like Exparel have been important to not only reduce pain, but also reduce the use of opioids and allow patients to get mobilized quickly. Critically, I think not using femoral nerve block so that the quadriceps isn't inhibited, no catheters, no PCAs, and no pain pumps have all allowed patients to do better and utilize less narcotics. And then use of anti-inflammatories and Tylenol as opposed to narcotics is really important. So when we talk about effective pain control after total joints, we know that multimodal analgesia has been helpful. And as a result of getting rid of femoral nerve blocks or PCAs, we've had kind of the same level of pain control, but reduced use of narcotics. We've had faster mobilization and early physical therapy participation. In our older patients who have reduced fall rates and decreased length of stays with improved discharge dispositions. So patients going home as opposed to skilled nursing facilities. And then our satisfaction surveys with HCAHPS scores have been better. And obviously as a result of all of this has been a significant reduction in the cost of that patient's care. This is an example of a total hip at the top and a total knee at the bottom pathway for non or minimal narcotic utilization. Again, intra-op and preoperative focus is on utilization of non-narcotic medications such as anti-inflammatories and Tylenol.
Okay, we're going to talk about VTED risk standardization and optimized blood management. This goes hand in hand with Ritesh's discussion of minimizing narcotics and using maximal pain relief methodology. TXA is the single biggest improvement in total joint replacement delivery that we've had in the last 20 years. When you decrease blood loss, decrease swelling, and decrease bleeding, obviously pain control and blood clots become less likely. So TXA is really a key. We've also moved to rapid rehabilitation, which has decreased the number of VTED events. Patients are in the hospital less. So we've minimized the amount of aggressive anticoagulation we use. The SCIP and AAOS guidelines have allowed us to do that, and we've used sequential pneumatic compression devices in the hospital, plus or minus out of the hospital, with aspirin in the vast majority of patients to minimize our complications from aggressive anticoagulants and to make it easier for the patients to mobilize without swollen limbs with hematomas in them. We don't use a transfusion trigger. We only use symptoms as our reason to give patients blood transfusions. Restrictive, conservative surgical measures, try and minimize the blood loss, no drains, regional anesthesia, and TXA wherever possible, IV or PO, if it's possible, local, if it's not, and avoid aggressive anticoagulation and use aspirin and boots, and your patients will be a lot happier.
Okay.
We're going to move it on to Jim, who's going to talk about post-acute facility utilization.
Okay, so the fifth pillar is to try to minimize the use of those, and this slide here shows some of the reasoning behind that. If you look at the SNF and the inpatient rehab, which are the two blue bars on the bottom, you can see that our readmission rate was higher for patients who were discharged there than they were discharged home. You know, that self-care group at that time, that this was a smaller sort of a different type of group, and we are moving towards more home health services and the use of technology platforms to send more patients home with minimized services and self-care. But clearly we want to avoid those inpatient facilities because these readmissions not only represent complications, they represent significant costs and have a very big impact on the overall cost effectiveness of the bundle. So in that regard, we also wanted to try to optimize the patients' protocols that did go to these facilities. And we started by trying to partner with various facilities around our location so that we had facilities to cover the regions where our patients were coming from. And we worked on developing collaboration and partners with these subacute facilities. We worked on bidirectional electronic exchange of information. We developed protocols for weekly updates on our high-risk patients. We had interdisciplinary weekly calls, including care management as well as clinical people, to get updates and try to make sure we were optimizing the management of the patients. And we also met quarterly and developed report cards to try to rate how we were doing with these different facilities. And all of this was designed to increase our involvement in care of these patients after they had left our facility by using these partnerships. This slide shows some of the results, and we had some success, but we quickly learned that the greatest success came with our partners for whom we had direct relationships with. So if you look at the purple line, which is on the bottom, that's one of the facilities that we had a direct relationship with because it was aligned with a institution that became part of NYU. And we see that we were able to get the length of stay down to about 11 days at that facility. But our other partner facilities, the average length of stay, despite all of our efforts, stayed right around 21 days. And we didn't really have as great an impact on that. And so it became very clear that having that direct relationship was much more successful, even with the partnership efforts that we made to keep the length of stay down in those post-acute facilities. The other thing that we developed a strategy for was, and this shows talks about the cost effectiveness, but the general concept of could we keep patients in the hospital if you have the beds available to do this for extra days in order to give them a little bit extra rehab, make them a little bit more independent, and allow for a home discharge rather than get them out of the hospital very quickly, but have them not be able to be discharged home and go to a inpatient post-acute facility. And what we found when we looked at the cost of this, because most of the cost of the inpatient stay occurs in the first day, mostly in the operating room, those extra days have very low cost. And although they're slightly higher than a post-acute day, because we could get them out faster, you can keep patients up to an extra 5 to 6 days in the hospital. And as long as you discharge them home, the cost is going to be less than discharging them after the 2 or 3 days and sending them to a post-acute facility where they're going to stay anywhere from 11 to 21 days or more. And so this is a strategy that you can use to improve the cost effectiveness, to allow for home discharge, keep the patient in the house for an extra day if that's what they need in order to get to the point that they can go home safely.
Ritesh?
So I'm going to talk about data, the importance of data, making sure that data is transparent, that data is real time so that you can make some actionable plans, making sure the data is believable and that obviously it's very accurate. So as we look at data on the next slide here, when we look at data and look at physicians or departments, you sort of say first you look at physician resource utilization and analyze the quality of the outcome that's present. Then you can transparently have that data be available looking at department averages, physician discharge, as well as the cost of care comparisons. And one thing that we do is you can look at this data physician to physician in a very transparent way, which then allows physician behavior to change. This is the example of that, is if you look at kind of quality and you said, okay, if the quality metrics were venous thromboembolism, readmissions, or surgical site infections, and you allowed all the physicians to have an opportunity to see all the data very transparently, making sure that it's accurate, believable data, you can see here that you can get an idea of the average length of stay, discharge disposition, and then readmission rates around episodes, which then can be displayed in a different way using cost, both as a direct cost for the admission, but also as a cost of the discharge disposition. As Dr. Slover was talking about earlier, kind of that avoidance of a skilled nursing facility.
So here are the spends by NYU over time after we implemented POSH and some of these other programs. You can see our spend went dramatically down. We took our spend from 37,000 down to close to 25,000, and now Jim has continued this work, and we're down in the 23, 24 range. But as you see, we're getting closer and closer to the hospital cost associated with the DRG for CMS, and that is really a race to the bottom. The more successful we get, the closer we're getting in some of these new paradigms to just a 90-day DRG for everybody, where the costs of these bundle payment programs will only award us enough to take care of them at a minimum of profit. And it's going to be interesting to see where the bottom is. So using these disciplines is going to become critical so that you don't lose money on a CMS product line. And then I've got bad news for you. The commercial payers are very rapidly going to adopt this methodology. So I think taking a chance and maybe going into one of these voluntary bundle payment programs may allow you to become more facile and be more successful in the private arena when you're asked to bundle your program. If you don't have the data that Ritesh was talking about, you're not going to be able to predict cost and be able to decide if you're going to go forward with a bundled program. I'm going to turn it back over to Ritesh. Whoops. Previous. Yeah, sorry.
So one of the important sort of mathematical concepts here is the idea of value. Value, we know, is outcomes over cost, but it's outcomes that matter to patients. And so theoretically, if we were to look at the equation and say we could improve value by decreasing the cost by 50% and also decreasing the outcomes by 10%, theoretically you've created value. But we know that in healthcare, poor quality is not acceptable. And so any decrease in cost cannot result in a decrease in outcomes. So one concept here is the incremental cost effectiveness rate, or ICER. If you look at this, you said, okay, a good ICER would be something that would increase costs and also equally increase outcomes. But something better might be that you could decrease costs without changing outcomes. And so the best case scenario, best example of this is tranexamic acid, is that you decrease cost while simultaneously improving quality and improving outcomes. So when we think about creating value, we want to decrease cost, and we want to not cause a decrease in outcomes. And when we look at sort of ICER in that concept, we say, here are a few things that can be increased costs, but they must add value, right? So routine laboratory testing can be $25,000 or more for the lab. Blood management, TXA, has been enormous in terms of assisting with cost effectiveness and providing improvement in quality. Use of autotransfusion devices and antibiotic cement are also examples. Reference pricing is important, and Dr. Iorio will speak about this later on, but establishing a ceiling price for commonly used items like implants, decreasing operating room waste, and then decreasing complications and readmissions, as Dr. Slover spoke about earlier, and decreasing admissions to a skilled nursing facility after their admission to the hospital. A lot of different fields have this graph, which is that we know that there are high volume centers that result in improved outcomes and decrease outliers. So looking at that same concept in the state of New York, again, higher volume hospitals had a lower infection rate when compared to lower volume hospitals when they underwent total hip replacements. There was a slightly higher total hospital charge.
So we need to approach change in a new way, right? We can't do it the old way that we did it in hospitals, where we just, we form a committee, we get 20 people in a room, we hire more people, and we approach a problem. We're going to need technology to help lead this change, right? So we need historical data and quality metric analysis. If you're not a big enough hospital to have financial metric analysis within your walls and accurate accounting, you need to get it from somewhere, and there are a number of companies that will help you do that. There are a number of big companies that will help vertically integrate your product lines and give you that information as well. You have to pay for it, but to go into this blind without that cost data is just foolishness. You need resource utilization and patient optimization. There's a number of platforms out there to do this. They're popping up like groundhogs on the prairie. There are pluses and minuses to each of them, and the more bells and whistles, obviously, the more cost. But for a couple $100 a patient, you can get a pretty good platform to help manage your patients, and that's a lot cheaper than a nurse practitioner or a nurse managing them in the hospital. Care management platforms are available as well as postoperative care and rehabilitation. Or you can have one platform that does all of these things, which also does your PROMs and your quality reporting requirements and plugs into some of the registries. And this is the way we're going to work going forward. Most of these things are compatible with your EMR. Your EMR will not do these things. They may tell you it will, but it won't. You're going to need workarounds from some of these other technologies to do that. If you try and build prospective dashboards and quality metrics out of Epic, good luck. You can do that, but it's difficult. And getting Epic to do it will cost you a lot of money. But there are vendors out there who do it for you. And then there are risk-sharing partners who will go into bundles with you and help you manage them if you can't do it yourself. But I think if you follow the tenets that we're speaking about today, you can do it yourself if you have motivated physicians aligned with their hospitals. So we're going to talk about value-based implants, right? Implants are always the bugaboo. It can take up to 40 or 50% of the DRG. The increase in cost of implants is insane. They've gone up about 8% a year up until very recently, where they've begun to sneak downward. And I think that's going to continue. And just like generic pharmaceuticals, generic implants can bring in billions of savings. And once a so-called mid-major company or generic implant manufacturer that has all the bells and whistles in the U.S. has a little bit of a track record, you'll see a remarkable change, and it's already beginning now. These are the 25 or so companies that are making these implants. They don't look very much different than the implants that the major 5 companies make, and they're available for a lot less money, albeit with a lot less support and a lot less options. So buyer beware, but the cost savings is immense for a routine primary joint replacement. The first step is physician alignment. You've got to remove the unnecessary costs, and you've got to understand where the value is. You know, the industry will suggest that these products are inferior, but I would tell you that if you put a mid-major company up against the big boys, they don't want to lose any volume, and just the threat of leaving may get you some price concessions from the major manufacturers. And as reimbursements decline, delivering these implant procedures in smaller facilities or subspecialty facilities like ASCs or some of the other delivery system facilities that are smaller than acute care hospitals will then make it much more easy to transition to other implant systems. And the surgeons will understand that they can have the same quality to which they're accustomed to at a greatly reduced cost, and that will start driving the change, especially since the surgeons drive much of the care in the ASCs. And then the hospitals and the ASCs can once again become owners of the implants, the instruments, and the process that allow these savings. And I think this process will happen over the next 10 years. In the end game is what happened at NYU. The large companies will come to the table with value-based pricing because they don't want to lose high-volume customers. Initially, they'll only offer their second-tier implants, but eventually with volume commitment versus fixed pricing, they'll come around and all the implants will be involved in the discussions. And we were able to secure quite a reduction in price, but we had to commit to 75% of the volume at our facility, which our physicians gladly did since they had some upside in the cost savings. Ritesh? I'm sorry, Jim.
Okay, so I have, I'm going to talk about what's next, so the impact, what are the next targets. So home health services, there's we spend a lot of time talking about how we want to steer patients home with services as opposed to having post-acute inpatient stays, but there is still quite a bit of expense to those services as well as to the home and outpatient physical therapy. And I think efforts to minimize those in an appropriate way, to use technology to deliver some of those services are going to be the next target, because we've made so much progress with the use of post-acute facilities and have those rates down so low. Same-day discharge, we're going to be talking about that a little bit, but that is one way to start to reduce the spend on the acute care hospital for patients in whom it's appropriate. The use of technology that does not have any clear benefit or whose benefit is unknown or very long-term, such as the robotics, use of different alignment devices or coagulation devices or anything like that. We talked a little bit about reference-based pricing in terms of the implants, and in the future there may be models in which the patient has some incentive to use lower priced implants that are equally effective. And down the road, we're probably going to be managing, as Dr. Iorio talked about earlier, populations of patients who have arthritis throughout the continuum of the disease, in which total joint replacement will be paid for from the pool of money to manage them throughout their entire life with arthritis. So I think things are definitely changing, and even though bundles represented a big change, they're probably not the last change. It's hard. One of the challenges with doing a bundle payment program with total joint arthroplasty is that you're looking at a relatively short period of time for an operation that's meant to last patients years to decades. And so it becomes very difficult to measure value based on just those short-term outcomes. Certainly we want to minimize those short-term outcomes and their effect on the bundle in terms of readmissions, but we still want to do what's best for the patient in the long run. And again, this is an operation that's meant to last them for years or decades. And so assessing value across that continuum is going to be the challenge in the future, where we're measuring value throughout the entire arthritis spectrum, from the time they get arthritis to a joint replacement to hopefully many years afterwards of enjoying the outcomes of that joint replacement. So what are some of the other things that we can look at? Well, there's a lot of imaging that's becoming more and more sophisticated. This may have some role, but again, it's going to be difficult to assess in a 30 or a 90-day period what the positive impact of something like that may be. Different bearing surfaces for the implants. Again, the impact for those is not likely to be felt in the first 30 to 90 days, but may have some value for the right patients when you consider a time frame of 10, 20, 30 years or more. Dual mobility sockets, which attempt to address some of the issues of stability and total hip replacement. Again, many of those are going to be addressing issues that may occur outside that 90-day bundle, but it may have value for select patients and determining who those are and when it's best to use them. Balancing techniques and robotics for helping with hip and knee replacement. Again, not likely to have a major impact on the patient's outcome over the short term, but may have an outcome, a positive impact over the long term, as well as the survivorship of the implant when you're looking at years to decades. Navigation, custom implants. There's some anti-allergy or hypersensitivity implants that may be appropriate for some patients. And there are many other innovations along these lines coming down the way. And we're going to have to evaluate these and try to measure the value for the patients, not just in the short-term bundle, but again, over the lifetime of an operation meant to last years. So I think, you know, this is really going to be the challenge, and this slide really talks about this. You know, the cost effectiveness when you look at technologies is going to be, for some of these things, is going to be very dependent on the patient's age and how long they are going to have the implant after it's done. I think younger patients are going to be more likely to be benefited from a cost-effective standpoint from a innovation that may affect the long-term outcome, even though it does not have a effect on the short-term bundle. It's very difficult with joint replacement in general to assess these type of changes and innovations because it's such a successful operation to begin with. There is some level of dissatisfaction with knee replacement of 10, 15, or 20%, and that may provide some opportunity to evaluate things that can impact that. The number is lower for hip replacements, and so it becomes very challenging for us to adopt these new technologies and to evaluate their value when you have an operation that's so successful at its baseline. But nonetheless, I think it's worth doing. Patients are having these operations at younger ages. Patients are living longer. And so we want to make sure we create value that's not only there for the episode or the first 90 days, but throughout the lifetime of this implant, which we can hopefully improve.
Ritesh?
So same-day discharge total joints, outpatient total joints aren't necessarily synonymous, but same-day discharge total joints here is kind of what we're talking about. If you look at, you know, back in 1986, the average length of stay for a total joint was 10 days. Right now, there's a tremendous amount of interest in same-day total joint replacements from initially physicians and patients, but currently payers are very much interested in this as well. One forecast or projection from a healthcare intelligence company, SG2, projected that the number of outpatient total joint replacement procedures was going to increase by 400% in the next decade. So if you were to extrapolate this, that would translate to about 40% of all hip and knee replacements done by orthopedic surgeons in the United States by 2027. When they looked at about 3,400 patients who had total joint replacements in 2016, they found that if they used the criteria, and the medical criteria used was no active coronary artery disease or arrhythmia, no chronic use of anticoagulation medications, no patients with moderate to severe OSA, hemoglobins that were over 12 and a BMI less than 40. And they used other sort of non-medical criteria like, you know, patients being in agreement with this, patients having assistance and having a coach, both the patient and the coach attending a educational seminar preoperatively, and then excluding Medicare. So when they looked at this, they found that 70% of patients were eligible for same-day discharge, and over 1/3 of Class 3 ASA grade patients could be eligible as well. The most frequent cause of ineligibility was obesity with a BMI over 40, and then severity of medical comorbidities, and then untreated obstructive sleep apnea. We look at satisfaction from total joint episodes. You also find that HCAHPS scores for same-day discharge total joints versus in-hospital total joints were higher. So same-day discharge is higher for HCAHPS scores from communication with nurses, staff responsiveness, physician communication, but also hospital cleanliness and some of the hospital metrics that are used, pain management, education regarding discharge information, and then ratings to the hospital as well. Look at the future. Same-day discharge, there's 3 main venues that same-day discharge total joints can be done in. 1 is the hospital setting, 2 is the ambulatory surgery center setting, and the 3 is kind of a specialized orthopedic facility that could allow 23-hour stay, like examples there. If you look at same-day discharge compared to non-same-day discharge is about 50% more profitable. And then even in Medicare patients that had same-day discharge, which was about 6% of the cases, there was a higher margin compared to non-same-day discharge Medicare patients, which is about 18% to 5%. If you looked at that and translated that to the NYU experience, the outpatient space would expect about a 20% increase in profitability. I think a chart on the right here that you see as secondary exclusion criteria for same-day discharge is important. Although it's not strict criteria, it can be relative criteria for excluding patients as well.
All right, we're going to have to fly through these last 4 or 5 slides, but the inpatient-only rule problems are upon us. Suffice it to say there's a great deal of confusion about this. CMS's intention was not to make this an auditable offense. What I would suggest is that you create a documentation system that applies to 90% of your patients being eligible for inpatient admission. And then if they do not satisfy the 2 midnight rule at the end of that because they improved quicker than you thought you would, then I would just document that. I would suggest that 5 to 10% of your patients may be eligible for outpatient admission or observation and not staying for 2 midnights. And I would document them that way as well, suggest that they're healthier than the normal patients. And then if they stay for 2 midnights, you could switch them over to inpatient stays. Jim, quick.
So CJR, this essentially it was scaled back a little bit because CMS decided that they wanted to be a voluntary program, may be more effective, and so it's currently mandatory in 34 geographic areas compared to 67 when it first started. If you look at it, they showed no statistically significant difference in the quality of care when they looked at readmissions, emergency department visits, and deaths when they compared patients who were in the CJR program compared to hospitals that were not. But they did note a decrease in payments. So they essentially showed that they could, at a decreased cost, deliver care with equal quality using the CJR program. And so the question is, where do we stand now? Well, when they looked at the, again, the CJR program and compared it to the BPCI program, they found that the 2 groups had similar baseline risk, exposure, quality, and costs, but that the BPCI hospitals, which were more large teaching-intensive academic centers, did have higher costs attributable to post-acute care and rehab facility costs. And their conclusion from this was that both voluntary and mandatory approaches, so the mandatory CJR and the voluntary BPCI, can have a role in engaging hospitals in the bundle payment program and generate results that can be generalizable. And so that both strategies may be engaged in the future in order to target hospitals to engage them more in bundle payment programs.
Pritesh, quick.
So quickly, kind of the original program compared to the BPCI Advanced program. The BPCI Advanced program will start on October of this year. It's going to replace the previous BPCI program, which is at the end of September. It's a short timeline, so we know that the application for the hospitals or physician groups deadline was March 12th of this year. And the new program, BPCI-A, is limited to kind of the prior Model 2 bundle, so no longer the Model 3 with post-acute care initiators or options to kind of choose a follow-up time frame. Unlike the prior program, it locked in for 2 years of participation if you sign up. And current CJR hospitals are excluded. The BPCI hospitals in the mandatory CJR cannot switch to voluntary BPCI-A. CMS is going to allow you to retroactively withdraw all or some episodes from this model in March of 2019. Kind of gives you a 6-month time frame for this. And the idea here is that, again, BPCI Advanced involves retrospective reconciliation of payments. So comparison of fee-for-service Medicare spending for all clinical episodes, and then the hospital is going to try to beat that target price. If you beat the target price, then you get a bonus. If not, then you have to get some payment cuts. If you look at kind of participation in the model, it's scheduled to start October 1st. And again, there'll be a 6-month window where you can have voluntary withdrawal of all or some of the episodes.
All right, so bundling drives incentives and alignment drives outcomes. The more hospitals and physicians get together to administer these things in a non-fee-for-service way, the better pricing becomes and the better quality becomes. And while methodologies may vary, academic hospitals provide service line reinvestment where doctors can create better value, whether it's for research or expanding a fellowship program. And in a private practice model, surgeons, when they're not in the reimbursement model per se, rather would not participate. And if the hospitals will gain share with them, it will drive change to improve the quality in those hospitals. So improvements in technology and efficiency can continue to improve the delivery system in a value-driven model. And we think we've proven that at NYU and other centers, and we encourage you to try some of these methodologies to improve your quality and decrease your costs. So thank you. We're glad to take your questions. There's a couple of them on my screen. One of them, Ritesh, has to do with the pass-through of implant costs to ASCs and whether or not you can charge for implants based on their cost. I'm sure there's different determinations for Medicare versus private insurers, but why don't you take that one?
Yeah, so implant carve-outs, I think that there are methods to do that. My practice with the ambulatory surgery centers that I belong to were bundled payments with some of the private payers, so that carve-out for implant cost is not there. And so the kind of the same concept as, you know, the hospital regarding the cost of implants applies to the ASC as well.
Yeah, I agree. That's what we've found. Jim, there's a question about using proton pump inhibitors or other gastric mucosal protectors because we're going to use all these NSAIDs and Toradol for these new pain programs. I mean, I agree that we're going to avoid narcotic issues, but we may gain a lot more ulcers and bleeding. Is that part of your standardized protocols and order set?
Yeah, all the patients are getting it in-house, and then patients are getting a script to go home with it as well. And then it becomes an individual with the surgeon on how long it's continued for. But we are giving it in-house, and it is a concern that we're definitely going to have to be aware of because we are using a lot more NSAIDs to make up for those opioids.
And there was another question about how do we address variation in implant usage for physicians. Well, that's something you have to do individually at each institution. If you want physicians not to use high-priced implants and you want them to cut down on the cost, there's no evidence that a higher cost implant is necessarily a better implant or lasts longer. I would suggest that those physicians need to be brought in to the discussions, and they need to share in the savings that the hospital would garner if they used a less expensive implant, and come to some agreement on their own. How you do that, there's a lot of methodologies for implant cost savings. There's ceiling price, there is vendor volume concessions, where the higher volume vendor will give you a discounted price. There's a lot of different reasons to do one or the other, depending on whether you're a teaching institution or not, where we want to have a great variety of implants, or a fellowship program. But if you're in a private practice out in the community, choosing one vendor can be to your advantage. It cuts down on a lot of the confusion. Your inventory is always in place. They're more likely to leave revision instruments or other parts of your armamentarium in place, rather than coming in and out for just-in-time inventory. So I think there's a lot of advantages to going with less vendors rather than more, as long as you have enough of your bases covered for the differences in the procedure types. There was another question about what is Move Health. Move Health is one of the vendors for outpatient surgical facilities. They build care delivery suites where you can do joint replacement as an outpatient. White Picket Fences is another company. There's a number of those companies out there now that will build a facility for you. It will use a lot of the technology that we talked about here. They will share costs and profits with you. They'll build it for facilities, they'll build it for hospitals, they'll build it for surgeons, and they'll partner with you. So there are a number of different ways to do this. Doesn't necessarily have to go through the hospital, but that's always a possibility. All right, so I think we've reached the end of our time. It's now 3 o'clock.
Perfect. I want to thank Dr. Iorio, Dr. Slover, and Dr. Shah for this excellent presentation, and to our audience for participating today. I also want to note that Dr. Shah and Dr. Slover will be speaking on current trends for success in bundles and strategies for financial challenges in orthopedics and beyond at the Becker's ASC meeting this month. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.